All right, so welcome to Introduction to CPC. I am Tiffany Roach, and I have, as you can see, alphabet soup behind my name. I actually have one additional credential that I just got, and I forgot to add it to the slide last week. So I also have my CEMC, which is the Evaluation and Management Coding Certification. So you can see here that I have lots of letters behind my name. I've been in the industry since 2016. From an education standpoint, from a coding standpoint, I've been in the industry since 2007. I've worked in various roles, between insurance payers, between doctors' offices, and things along those lines. So, the first thing that we're going to talk about today is the business of medicine. So, just kind of not coding related, but just kind of like how the office runs, a little bit, how to decipher your medical records and things along those lines. So, healthcare itself is going to be a multifaceted industry, which will employ many different types of professions, and it is going to be bound by a multitude of statutes and regulations. In order to help you understand how a coder fits into the healthcare industry, we will discuss coding as a profession, as well as how the coder fits into the physician's office, as well as the differences of services that can be provided by hospitals and then those that are provided by your physicians. Although some coders will not be involved with the billing process, it is important to understand some of the billing aspects in order to perform your job duties more effectively. We will discuss the different types of payers for medical services. We'll talk about the RBRVS system for the fees, medical necessity, and then the advanced beneficiary notice, or the ABN, as it relates to your physician services. So it's also important to discuss the varying regulations that do affect us as coders. So this will include privacy and security, and then compliance rules and audits, as well as using tools such as the OIG work plan in order to identify any possible areas of concern. So every time a patient receives any type of health care, a record is going to be maintained of the observations, medical or surgical interventions, as well as your treatment outcomes. This record itself includes information on the patient concerning his or her symptoms and their medical history, the results of any examinations that are done, reports of any x-rays or any lab tests, diagnoses, as well as any treatment plans. Your medical records and your health information technicians will organize and evaluate these records for completeness as well as your accuracy. So coding itself is going to be the process of translating that written or dictated medical record into a series of numeric or alphanumeric codes. Your coders will regularly communicate with physicians and other healthcare professionals in order to clarify any diagnoses or to obtain any additional information. Coders will use any computer programs to tabulate and analyze data in order to improve patient care, to help better control your cost, provide any documentation for use in legal actions, and it is possible to have it be used for any research studies. So those who specialize in coding are going to be called medical coders or coding specialists. Medical coders will assign a code to each diagnosis and procedure by using a classification system. Your coders can use several different reimbursement systems, such as those that are required for ambulatory settings, physicians' offices, or your long-term care. Most coders will specialize in coding your patient's medical information for insurance purposes. Physician-based coders will review your charts, assign codes from the CPT, HCPCS, and ICD-10-CM code systems for your insurance billing. This will be tied directly to your physician's reimbursement, and careful thought to assigning your correct codes is going to be essential for your physician's livelihood. Now, those who specialize in coding for hospitals, they are typically called health information coders, medical record coders, coders and abstractors, or coding specialists. These technicians will assign a code for each diagnosis and procedure, relying on their knowledge of the full disease process. Coders will then use their classification systems to assign patients to one of several hundred Medicare severity diagnosis related groups, or MSDRGs. And those MSDRGs will determine the amount for which the hospital will be reimbursed if the patient is covered by Medicare, or there are going to be other MSDRG systems that your other insurance, like your commercial payers, will use. You also have your risk adjustment coding, and that will focus on diagnosis coding using your ICD-10-CM code set. Your risk adjustment diagnoses are going to be pulled from claims and medical record documentation in all of your settings. And those risk adjustment coders can work for health plans, providers, or other healthcare entities. So in addition to mastering your anatomy and medical terminology, your coders do have to be very detail oriented. Simple words such as if and or can completely change your code selections. So paying special attention to many guidelines when you are learning your coding is going to be necessary. So let's go back to our physician-based billing. When you visit your physician's office, you'll typically get a single bill from that physician. Although you can get a second bill from another physician, such as a radiologist. When you visit your hospital, then you can typically get a bill from the hospital itself, and then you'll get a bill from each one of the physicians that are involved with your care. Codes for your physician services will report the work and the overhead of the physician, regardless of where the work is performed. So a physician can provide inpatient or outpatient services, and they can provide those that can be done in a clinic, ambulatory surgical center, a hospital, your home, basically anywhere the physician can go, they can provide their services. Those physician services are going to be reported using CPT, HCPCS, and ICD-10-CM codes. And then they will typically be billed on what's known as a CMS 1500 form. Now, your codes for your hospital services, those will report the technical component of the services that are provided in the hospital facility or in a building that is owned by the hospital. So these services are to cover the costs of the hospital itself and the overhead of the equipment, the technicians, the nurses, the janitors, and any other supplies that are provided by the hospital. Your hospital services are reported using ICD-10-CM and ICD-10-PCS codes, and they're grouped into payment classification systems such as your MSDRGs and your APCs. Now, your hospitals will typically bill on a UB04 claim form. Your physician services are going to be provided by a variety of your medical providers. Each provider will have differing levels of education. Your physicians will undergo your 4 years of college, 4 years of medical school, and then an additional 3 to 5 years of residency. Now, that residency is going to be training in a specialty of practice. A physician can continue training into a subspecialty, and that's going to be referred to as a fellowship. Your physicians often have mid-level providers working within that same office. Those mid-level providers will be your physician's assistants and your nurse practitioners. Those mid-level providers are also known as physician extenders because they do extend the work of the physician themselves. Your PAs are licensed to practice medicine with physician assist or with physician supervision. And a PA program takes approximately 26 and a half months to complete on top of the 4 years. So they don't go to full medical school. Your nurse practitioners, they will have a master's degree in nursing. Now, your mid-level providers are often reimbursed at a lower rate than your physicians. Although the scope of the practice will vary by states, most of your mid-level providers will require oversight by a physician. Each state will have their own regulations on the scope of practice that can be performed by each level of your providers. Although some patients will pay in full for their own medical expenses, most of your patients will have some type of insurance coverage. As a coder, it is important to understand the individual payers and some of their coding requirements that are going to be specific to each of the payers. So your insurance carriers can be broken down into two groups. You have private and governmental. Private carriers can also be referred to as commercial carriers, and they may also provide governmental plans such as your Medicare Advantage plans in addition to those private or commercial plans. Your commercial carriers can offer both group and individual plans. Your group plans will often be offered through your employers, and then your individual plans will be those that can be purchased directly from the insurance carrier. So some examples of your commercial carriers can be Blue Cross Blue Shield, Aetna, Cigna, United Healthcare, and so on and so forth. Government insurers, those are going to include Medicare, Medicaid, and TRICARE. So Medicare is administered by the Centers for Medicare and Medicaid Services, or CMS. And then Medicaid is going to be a combination of federal and state resources. And then TRICARE will be for your armed forces personnel as well as their families. Medicare itself is going to be broken into multiple different parts. Part A is going to cover your inpatient hospital care, as well as any care that's provided in skilled nursing facilities, hospice care, and your home health care. Part B will be those medically necessary services that are done by physicians, any outpatient care, and other medical services that are not covered by Part A. Your Part C insurance, that is going to be called your Medicare Advantage, and that is going to be managed by your private insurers, and they can have a combination of Part A, Part D, and then sometimes Part D services. And then your Part D is going to be your prescription drug coverage program, and those are going to be available to, again, your Medicare beneficiaries. Coders that work in your physician's offices will mainly work with Part B or Part C Medicare Advantage plan. Now, when we talk about documentation, that is going to be the recording of your pertinent facts and observations about an individual's health history, including their past and present illnesses, any tests, treatments, and outcomes. The medical record chronologically documents any patient care to assist in the continuity of care between providers. It helps facilitate claims review and payment, and then it can also serve as that legal document. It is imperative that all of the services that are provided to a patient be supported and documented within your medical record. A coder will be required to read as well as understand the documentation within that medical record in order to code accurately those services that are rendered. Different types of services that are going to be documented within the medical record could be your evaluation and management services, any operative reports, x-rays, labs, and so on and so forth. Now, those evaluation and management services are often provided in a standard format such as SOAP. Not all of your medical documentation will be documented in a clear SOAP format, but all of your charts should at least contain those individual components. So your subjective is going to be where the patient's, or is going to be the patient's statement about their health, including their any symptoms. So here we have a patient has no known allergies. She is diabetic since 2012. She takes 81 milligrams of aspirin daily. Medication list is noted. The patient is here for their annual diabetic foot check, and she does have diabetic shoes as well as denies cigarette use or tobacco use. So basically, again, in the patient's words, why are they here? The objective is going to be where the provider assesses and documents the illnesses using observation, palpitation, auscultation, and percussion. So it's just going to be what was that physical examination that they did. Your A will stand for your assessment, and that's going to be the evaluation and conclusion made by the provider. That is going to come from the physical examination, as well as taking into consideration the subjective portion of the exam. And then lastly, you have your plan, and that's just going to be the course of action based on the assessment and the objective, the exam. Your operative reports are going to be a little bit different. So they are going to be used to document the detail of a procedure that is performed on the patient. Most of your operative reports will have a clear header and then a clear body of the report. So the header of the report could include the date and the time of the procedure, the names of any surgeons, co-surgeons, and assistant surgeons. If anesthesia is used, the type as well as the anesthesia provider name, any preoperative and postoperative diagnoses, the actual procedure that was performed, and then if any complications were present or did come up during that procedure. And then the body itself can include basically just a description of the procedure. Okay. So it's going to go into detail of what the procedure was, and it's going to tell them how they did it. It's going to be basically a breakdown walking through how that procedure was performed. So approximately 20% of an operative report will contain words that are less important to you as a coder. You will be tasked with breaking down the information and then applying the correct codes. As you read through the note, you will want to highlight any terms that are unfamiliar to you. This will help you remember to research those terms so that you have a better understanding of the procedure that is being performed. So in this example, if you're not familiar, then you would want to highlight those terms here to help understand what intra-articular means, authorized, any abbreviations such as your ACL or your SMC, and then the anatomic location of an anterior horn and a posterior horn of the meniscus. So it's just kind of one of those things that everybody's going to look at your notes differently. Everybody's going to have different words that they're going to pull out, just because everybody's going to have different knowledge as far as what certain words are and anatomic locations. When you have your diagnoses, again, you should have your pre-op and your post-op diagnoses. Sometimes they're going to be same, sometimes they're going to be different. So if they are different, we always want to use our post-op diagnosis because that's going to give us more definitive detail about why the procedure was being done. So we could go in thinking that it's one thing. We go in to perform the procedure and we realize that there's a different scenario or a different condition, and that might change the procedure that we do. So we always want to go with that post-op diagnosis, as I said, just to make sure that, we're always reporting the most accurate condition that is there for the patient. Your procedures that are performed that are in your header will give us an idea of where we want to start to make sure that we have the support down within the description of the procedure. So we never want to code directly from that procedures performed header. So like in here, we have the right knee arthroscopy. They did a lateral meniscus authorization as well as a lateral meniscal repair. You want to make sure that you read all the way through the description of the procedure and make sure that that procedure that you're coding is supported, to make sure that we're coding the correct procedure. Also, there could be different parts within the body of the report that are not listed in the header at all that we can report separately. So it is, again, important that you aren't coding from that header and you're just reading the full operative report to make sure that you're not over coding or under coding anything. And then again, same thing, you've got some keywords that you want to kind of take a look for whenever you're coding your operative reports. You want to look for any anatomic locations and structures, how the procedure was performed. So that surgical approach, was it done by an open incision? Did you use a scope? Was it done percutaneous? Things along those lines. Your procedure method, what were they doing? Were they doing a debridement? Were they doing any drainages? Were they incising, repairing, so on and so forth? The size and number, sometimes your code descriptions will differ based on the size of masses or lesions or areas that were debrided, things along those lines. And then any surgical instruments that were used during the procedure, that will kind of help you indicate whether or not it was a percutaneous, whether it was an open or with a scope. And then again, you always want to make sure that you read through the entire body. There's going to potentially be information within the body that could not be found within the header. You want to pay special attention to any documentation of a procedure that was abandoned, complicated, extensive, or if any extra time was used, because that could indicate that you need to report a modifier to either increase the payment or decrease the payment. So medical necessity basically just means that your services or supplies that are being given are proper and needed for a diagnosis or a treatment of the condition, that they are provided for the diagnosis, direct care, and treatment of the condition, that they meet standards of medical practice in the local area, and they aren't mainly just for the convenience of you or your doctor. So, for instance, if you have an ingrown toenail, it wouldn't be medically necessary to do an amputation of the toe, right? So you want to make sure that basically it's the minimum necessary for the treatment of the condition that will appropriately treat that condition. You do have regulations that govern your medical necessity found within the Social Security Act. So CMS will develop their policies based on items or services that are covered within that Social Security Act. They are not allowed to cover any items or services unless it has been put through legal requirements. The statutory and policy framework that your national coverage determinations are going to be made by, or that are made, may be found within Title 13 of the Social Security Act, as well as any Medicare regulations and rulings. So those national coverage determinations, or your NCDs, those will describe whether your specific medical items, services, treatments, procedures, or technologies can be paid for underneath Medicare. Your Medicare administrative coordinators, they are going to be responsible for interpreting those national policies into regional policies. And those are going to be called your local coverage determinations, or LCDs. Now, those LCDs only have jurisdiction within their regional area. So your MACs may also define what codes are needed for coverage in related medical billing and coding articles. So this is an example of what an LCD looks like on the CMS website. You do have different areas within the LCD. So you've got your contractor information up at the top. I don't have it expanded, But your contractor information is going to tell you what states or what jurisdictions that LCD pertains to. Underneath your LCD information, it's got your effective date, any revision dates, the titles, and then your LCD number. So if you do have to reference that LCD for any reason. And then underneath your LCD information, you've got your coverage determinations that will lay out specifically what is covered, what is not covered. Now, providers should use an advanced beneficiary notice when a beneficiary requests or agrees to receive any procedure or service that Medicare may not cover. So that ABN is going to be a standardized form that explains to the patient why Medicare may deny a particular service or procedure. That ABN will protect not only the provider's financial interest, but it will protect the patient as well, because if they don't sign it and they're not informed, they're not able to be billed. Providers are going to be responsible for obtaining an ABN prior to providing that service or item to the beneficiary. It has to be filled out in its entirety, as well as the cost to the patient and the reason why Medicare may deny the service. This form is the only form that can be used, and it cannot be altered in any other way other than to put the practice header at the top, and then obviously fill in your reasons as to why Medicare may not cover the service. The healthcare industry, again, we've talked about it, is going to be heavily regulated. So HIPAA is going to be known as the Health Insurance Portability and Accountability Act of 1996. It is a 5-part act. However, the part that's most concerning to the position of a coder is going to be Title II, and that's known as your administration simplification. So administration simplification will address national standards for electronic transactions and their code sets. It will establish unique identifiers to providers, health plans, and employers to be used nationally. And then it also provides federal protection for the privacy of personal health information. HIPAA does require that there is a standard electronic format for any transactions. And it was essential in moving forward with the transition from ICD-9 to ICD-10. So the code sets that are covered underneath HIPAA are going to be your HCPCS, your CPT, CDT, ICD-10-CM, as well as your national drug codes. It is important to know that although it does mandate the use of those specific code sets, it doesn't mandate the use of the conventions or guidelines for your CPT or your HCPCS. Those are going to be mandated and regulated by AMA, and then CMS for the HCPCS. The Health Information Technology for Economic and Clinical Health, also known as your HITECH Act, that was enacted as a part of the American Recovery and Reinvestment Act of 2009. It was signed into law in February of 2009 in order to promote the adoption and meaningful use of health information technology. Your subtitle D of the HITECH Act addresses the privacy and security concerns that are associated with electronic transmission of health information through several provisions that strengthen the civil and criminal enforcement of your HIPAA rules. Basically, HITECH strengthened your HIPAA rules, and it made businesses more responsible and helps them comply within HIPAA a lot easier and a lot more standard. Your HITECH will also allow patients to request an audit trail of health information that's made through any electronic records. Now, on the website for the Office of Civil Rights, you can find some examples of violations of your HIPAA Privacy Act. There's an example on there of a nurse practitioner who accessed her ex-husband's medical records. And she was reported to your licensing authority. And then she did have um, her access revoked. And then it was reported to the licensing authority, and all of that. So the main story is don't access things that you're not supposed to. Now, the OIG does acknowledge that patient care is and should always be the first priority of your physician. However, the practice's focus on patient care can be enhanced by the adoption of a voluntary compliance plan. A voluntary compliance program that can provide physician practices with many benefits, including faster and more accurate payment of claims, diminished chances of any payer audits, and then it also sends a signal to your employees that compliance is a priority. So as of now, the compliance plan is currently voluntary. There is an act that has come down the pike, where it will be more necessary to have compliance plans. That date has not been set at the moment, but it is coming. So that's why it's highly encouraged, so that once that date does come, then if you've already got a compliance plan in place, then you are good. So in October of 2005, the OIG has published the OIG compliance program for individuals and their small group physician practices as a guidance for the physician practices to create their own. There are going to be 7 key actions to successfully implement a compliance program. One, they want to conduct internal monitoring and auditing through the performance of periodic audits. They want to implement compliance and practice standards through the development of written standards and procedures. They want to designate a compliance officer to monitor compliance efforts and enforce your practice standards. You want to conduct appropriate training and education on practice standards and procedures. You want to respond appropriately to detected violations through the investigation of allegations and the disclosure of any incidents to appropriate government entities. You want to develop open lines of communication with your employees, with staff meetings, newsletters, and then other lines of communication. And then lastly, you want to enforce disciplinary standards through any well-publicized guidelines. Another report that's published by the OIG is going to be the work plan. That work plan is going to be updated on a monthly basis, and it's going to be found on the OIG website. Basically, it outlines the priorities of the OIG for the fiscal year ahead. So it's going to tell you what the OIG is looking at to help combat fraud, waste, and abuse. And just to kind of help you understand what's kind of on the radar to make sure that you are following all of the guidelines and things for the upcoming year. Okay. So we're going to talk a little bit about the ICD-10-CM code set now. It is going to be a code set that does indicate your signs, symptoms, diagnoses, and conditions. So the layout of the book, I know you probably don't have it, but the layout of the book is just going to follow this general guideline depending on the publisher that you get. So you're going to have coding conventions. You're going to have an index to diseases. You're going to have a table of neoplasms, a table of drugs and chemicals, an index to external causes of injuries. And then you're going to have a tabular list. That tabular list is basically going to give you your code descriptions. It's going to tell you when you can code things together, when you need to code them separately, any guidelines, things along those lines. And then you also have your official guidelines for coding and reporting, which will again give more detail about coding things together separately, any conventions as far as terminology, and things along those lines. So your ICD-10-CM alphabetic index to diseases and injuries is going to be listed in an indented structure. You want to be very careful in looking at your alphabetic index to make sure that you're selecting your correct code from that indentation format. So if you want to see the example here of your history in the index, you do have on the left-hand side, you have your family history. And then you've got on the right-hand side, underneath history, you've got a personal history. So it's important to make sure that you're following that indentation. And if you have a personal history, you're not coding from the family history and vice versa. Your table of neoplasms is going to be next. So you're going to have 7 columns within this table. The first column will list the body areas, and it's also presented in an indented format, just like the rest of your index. Your columns are going to be as follows. Your primary malignancy is going to be the site where your cancer has originated. Secondary malignancy will result from a metastasis, and it will form a new focus of that malignancy somewhere else. So cancer will commonly metastasize to the lymph nodes, the liver, the lungs, or the brain, but it can go anywhere. Those are just your common locations. And then that metastasize, that is going to be determined by your documentation. Your carcinoma in situ column, that is going to describe a malignancy that is confined to the origin site without invading any neighboring tissues. So the neoplasm itself is going to be encapsulated. So if you kind of think about the yolk of an egg, how it's got that sac around it, that's going to be kind of like the encapsulating sac around that neoplasm. Your benign neoplasms will not contain any cancerous or precancerous cells. They will typically grow slowly and they will not metastasize. Uncertain behavior indicates that your pathologist is unable to determine whether it is benign or malignant. It has characteristics of both benign and malignant cells, but your pathologist is unable to determine which one it is. This column should only be used on the basis that you have results of a pathology report. And then lastly, your unspecified column is going to indicate that a provider cannot or has not determined the nature of the neoplasm. Next, you have the index of table of drugs and chemicals. This is going to be used to identify any drugs and substances that cause your poisonings and your adverse effects, as well as when your patients are not taking enough of their medication, which could result in them remaining ill. All of the codes in this table will require a 7th character, and you should never code directly from the table of drugs and chemicals, and you should always verify your code in the tabular list. You do have, again, 7 columns within the table. The first column is going to identify your substance, and it's going to follow an indented format, just like the rest of your alphabetic index. You do have 4 different types of poisonings in columns 2 through 5. So a poisoning will occur when a drug is taken in the wrong dosage or it is taken in error. It's going to be used for intoxication or poisoning by a drug or other chemical substance. And these columns are going to be discussed if you take a course, it's going to be really, really discussed how to use the table, the difference between accidental, intentional assault, and undetermined. Your adverse effect column, that is going to be when a drug has been correctly prescribed and properly administered, but the patient has an adverse effect to the drug. So an allergy, a side effect, dizziness, something along those lines. And then lastly, you've got your underdosing column. That is going to be used to report when the patient takes less of a medication that is prescribed by a manufacturer or a provider. So this code in this codes in this column should never be assigned alone. They should always have your condition for which the medication is being prescribed, as well as the underdosing code. And then your next section is going to be the external cause of injuries index. The external cause codes are going to be used to describe how your injury has occurred. So if a patient has a broken arm from a fall, you can look in this index for fall, and then it will list your different types. Without further information about the fall, then you would just use your default code W19, and again, verified in the tabular list to assign your remaining characters for a complete code. The majority of the codes in this section will require your 7th characters, so you should always verify your code in the tabular. Okay, so you do have some conventions at the front of your ICD-10 guidelines. Your conventions and guidelines are going to instruct you on how to read your book and how to properly report and sequence your diagnosis codes. Once you get to that point, then you should take some time to review both your conventions and your guidelines. We'll talk about a couple of them here, but we won't go into them all. So your section 1A is going to be just for the general conventions for ICD-10-CM. And then section 1B is going to go into detail of your general coding guidelines and instruction on basic knowledge of using your ICD-10-CM book, such as if you have multiple coding for conditions, combination codes, acute versus chronic, signs and symptoms versus a definitive diagnosis, and so on and so forth. So you've got here just like a table of contents at the beginning of your guidelines, just to kind of help you find those. An example of an instruction that's found within your conventions is going to be the use of the abbreviation NOS. So NOS is going to mean that it is not otherwise specified. It's going to be the equivalent of an unspecified code, meaning that we don't have enough information from the provider to give a more specific diagnosis. Your parentheses in your index, these are going to enclose supplementary words. They're also known as non-essential modifiers. So if a provider were to tell us that they have migratory pneumonia, then we would look up pneumonia, and because migratory is in parentheses, then we would just use that line because all of our terms are located there. Here, our example for with. This is if the provider states that maybe a patient had diabetes with chronic stage 5 chronic kidney disease. Then it can be presumed that your diabetes and your chronic kidney disease have a causal relationship because you have a with entry within the alphabetic index. So here we would look up diabetes and then with, and then your chronic kidney disease, and that would tell us we should code E11.22 because they are related. You also have certain guidelines and references to your guidelines. So for instance, if you were to see a reference to a guideline for IC4A2, then that is going to tell you that you need to go to section 1 for the conventions, coding guidelines, and chapter specific. Letter C for the chapter specific coding guidelines. Chapter 4 for the endocrine, nutritional, and metabolic diseases. Letter A for diabetes, and then the second bullet for the type of diabetes that is not documented. Your codes can be as short as 3 characters, or they can be as long as 7. So if you have a chapter of codes, it's, for example, it is your chapter 4. It's going to be based on your body system or your condition. So chapter 4 is your endocrine, nutritional, and metabolic diseases. So it's going to be a section which is E08 through E13 or E00 through E89, right? Your chapter is going to be based on that full body system. Your section is going to be a group of 3 character codes. So your diabetes mellitus section, that is going to be E08 through E13. A category is just a 3-character code number. So E11 is a category that describes type 2 diabetes mellitus. And then you've got subcategories that can either be 4, 5, or 6 characters that are going to fall underneath your categories. And those can be based on, if it's a 4th character, that's going to define your site, etiology, and manifestation. And then your 5th or 6th character will represent the most accurate level of specificity for that condition. And then we talked about some that need 7th characters. So some of your codes will require a placeholder in order to make the code long enough for your 7th character to be reported within your 7th position. So for example, if you look at the bottom of the screen, you've got T16.1. It doesn't have a 5th or a 6th character within the code. So we have to put those placeholders there, the 2 X's at the end of the code to make it long enough so that that 7th character A is placed in the correct position at your 7th spot. So T16.1 XXA is your valid code. But if you were to report T16.1A, that would be invalid because our 7th character would not be in the 7th position. So when we talk about locating an ICD-10 CM code, first we want to find our documented diagnosis within the medical record. Then we want to determine of that documented diagnosis, what is the main term of that diagnosis? And we'll kind of go through some examples here in a minute. You want to look that main term up in the alphabetic index. Once you find your code in your alphabetic index, you want to verify that code within the tabular. Make sure it's a valid code. We don't need to further expand it. And then we also want to review any conventions and codes or any notes that are associated with that code. So when we talk about our main term, we want to kind of think about what is the disease, the illness, or the symptom of that condition. So in the instance that you have acute bronchitis, then our disease, illness, or symptom in that is going to be bronchitis. And then our acute is going to kind of be that descriptor word, right? So acute is going to tell us the type of bronchitis, and the bronchitis is going to be the actual disease that is present. So in these examples here, you can see that our main terms for ruptured ovarian cyst, cyst is going to be the condition, the ovarian is going to be the location, and then ruptured is going to be a descriptor of that cyst. Abdominal pain, then pain is going to be the condition, abdomen is going to be the location. Chronic sinusitis, again, sinusitis is going to be the condition, and it's just the chronic form of the sinusitis. And then your febrile convulsions, you've got your convulsions is the condition or the disease, and then febrile meaning that it was caused by an increased temperature. So let's go back to the example of acute bronchitis. Our main term in the alphabetic index, we'll look up the term bronchitis because that was our main term. And then we'll go down in the tabular, or not, I'm sorry, not in the alphabetic index. We'll go indented into acute or subacute. And then we're going to use J20.9. We'll flip back in the tabular of the book to our J20.9 code. And then we also want to make sure that the code description matches. So acute bronchitis unspecified matches our acute bronchitis condition. But then we also want to make sure that we read all of our associated notes for that code. So our includes notes telling us that we could have additional terms that are used in here. Excludes one is going to tell us that it should not be coded using this code. So if they just tell us that the patient has bronchitis and there's no other specific documentation or details about the bronchitis, then we should use J40 instead of J20. Now our excludes two notes, that just means that it's not included here, but you can have both of the conditions at the same time. So if they have acute bronchitis and chronic bronchitis, then you can code both J20.9 and J42 for the chronic bronchitis as well. Okay. Any questions on ICD-10? I know that it's kind of a quick overview, but without really like going into the book or anything like that, then it's kind of hard to like get into a ton of detail. Okay. So lastly, we're going to talk about CPT, surgery guidelines, our HCPCS level 2 code sets, as well as modifiers. So when we talk about CPT, then our CPT is going to be the procedures that are performed, procedures and services that are performed by your providers. Your category 1 codes, these are going to be your medical procedures, evaluation and management, radiology, labs, any surgeries, things along those lines. Category 2, these are going to be located behind your category 1 codes. They're going to be identified by the letter F at the end of their code, and they're going to be optional performance measurement tracking codes in order to help facilitate data collection by the AMA and CMS regarding quality of care for your patient. And then your category 3 codes are going to be located behind your category 2 codes. They're going to be identified by the letter T at the end of their code. They're going to be known as your temporary codes. They're going to be used for data collection in your FDA approval processes regarding any new and emerging technologies, any services, or any procedures. So our category 1 codes, again, those are going to be 5-digit numerical codes such as 12345, 99213, and so on and so forth. These are going to be the codes that you will use most often as a coder for reporting your medical visits, any services, any tests, or any procedures that are provided by the physician or those other qualified healthcare professionals, such as your nurse practitioners and your physician's assistants. Your category 1 codes are going to be reviewed and updated on an annual basis. And then those codes will begin to be used on January 1st. It is mandatory when you are submitting a claim that you do use a category 1 code for reporting and reimbursement purposes. Each of your sections are going to have subsections, subheadings, and guidelines. Before your guidelines, you do have alternate coding suggestions that are going to be available that will aid the coder in finding your correct codes. The guidelines that appear below these suggestions will provide valuable information about the correct coding of procedures within the section. They will instruct your coders about how to add your services together or when to report them separately, when your items are going to be inclusive to other services, when you should use modifiers, and so on and so forth. So in your CPT, your category 1, again, you should spend time familiarizing yourself with those guidelines. Your category 2 codes, as we talked about, are going to be 5-character alphanumeric codes that end with the letter F. So you can see the example is 0001F. These codes are going to be used again for those performance measurements and then as a method for reporting quality to both commercial insurance carriers as well as your Medicare. Category 2 codes should never be reported on them or by themselves. And then while reporting of these codes is optional, then they should always be reported with another category 1 code. Then your category 3 codes, those are also going to be 5-character alphanumeric, and they will end with the letter T. So for example, 0042T. These are going to have temporary codes for reporting emerging technology, services, and procedures. Your category 3 codes can be reported alone. And there is an instruction or a guideline that tells you that if you do have a category 3 code available, then you should use that instead of an unlisted code in category 1. The CPT code manual is going to be laid out similar to your ICD-10. However, you're going to have your category 1 codes at the beginning. You're going to have note sections at the end of each one of your sections within the category 1. So your evaluation and management, your anesthesia, your surgery sections, and all of those. Then you'll find your category 2 codes and then your category 3 codes. You'll have appendices at the end that will help lay out modifiers, which we're going to cover those here in a couple of minutes. It's going to give you an appendix to help you code for like EMGs and your nerve function testing. You've got an appendix for your vascular families for your cardiovascular section. You've got an appendix that will tell you services that can be coded with telemedicine, so without having the patient physically in the office. And then our lovely COVID vaccines, there's a bunch of guidelines and different codes for each of your manufacturers, and then whether it's your initial or your booster or anything along those lines. And then after your appendices, you have your alphabetic index that's very similar to the index in your ICD-10-CM. Within the very beginning of your CPT manual, you do have instructions for the use of your code book, and there is a sentence in there that talks about not choosing a code that merely approximates the service that's provided. If the service is not identical to the code description, then you should instead use an unlisted procedure code. And those can be used by any qualified healthcare professional. So they can be done by a physician, a nurse practitioner, a physician's assistant, a physical therapist, depending on what type of provider you're seeing. You do also have an instruction about the importance of reading what's known as your parenthetical instructions within your CPT codes. Those parenthetical instructions are going to talk about how you can prevent significant coding errors. And then you also have a guideline or a paragraph in there that talks about accuracy and quality of coding by potentially referring to some supplementary resources such as your CPT assistant, your coding clinics, and things along those lines. So again, it's an added reminder of how important it is to know and understand your guidelines. There again is going to be an introduction of each section of the book, and then you have subsections found within each of the sections. Your guidelines will provide, again, your specific information about how to apply codes within that section, such as when to add them together, report them separately, when to use modifiers, definitions of what makes a service complete versus limited, etc. So you do have some icons and conventions throughout your CPT. So if you see a semicolon, that basically will divide the code description into 2 parts. You have your standalone or your common portion of the code descriptor before your semicolon. And then anything after the semicolon is going to be like just the rest of the code. So your standalone portion of the code is going to fall within each of the indentions underneath. You have a plus symbol that is going to indicate that it's an add-on code. Your add-on codes should never be reported alone. So they should always be reported with a primary procedure. If you see a red circle, it's going to indicate that there's a new procedure for the year. A blue triangle is going to indicate that there was a revision of the code description itself. And then your facing green triangles are going to indicate that a guideline has changed, that a parenthetical instruction has changed. Basically, anything other than a procedure descriptor has changed or it's new. If you have a circle with a line through it, then it just means it's exempt from the use of modifier 51, which is your multiple procedures. We'll go through that here in a little bit when we talk about modifiers. If you have a lightning bolt, that's going to indicate that that vaccine is pending FDA approval. And then if you have a pound sign, that's going to indicate that your code is out of numerical order, and it'll reference what code range you need to go look at to find that code. So as you're coding, we want to make sure that we review that documentation thoroughly in order to determine what services were provided. You will review your CPT index to find your code or the code range that would apply to those services. And then your codes can be found in the index by multiple ways. You'll look at either your condition, the procedure that's being performed, the anatomic site, if there's any abbreviations, synonyms, or so on and so forth. Once you've identified your code, you want to review the code in the code set itself, review the code descriptions, and then all of your guidelines and instructions for reporting that code that will help represent the service provided. Now, your NCCI, that is going to stand for National Correct Coding Initiative. Per the CMS website, the CMS has developed that NCCI to promote national correct coding methodologies, and it helps control improper coding that leads to inappropriate payment for your Part B claims. CMS will own the NCCI detail, and they'll publish it along with other resources on their website. You do have some commercial payers that do follow the NCCI edits as well. So it's important that you know what falls within your NCCIs so that you're making sure that you're getting correct reimbursement. When we talked about ICD-10-CM and they're based on the guidelines for their sequencing, CPT codes are going to be sequenced based on what's known as RBRVS. That's going to stand for your resource-based relative value scale, and it's an estimation of physician work, practice expense, and medical malpractice and liability. Those RBRVS values will be found on the Medicare website. And once your services have been coded or identified, then they are going to be sequenced with the highest relative value unit, or RVU, first, followed by any other codes in decreasing RVU order. So essentially, the more complicated or more complex your procedure, the higher your RVU, and those should be listed first and then in decreasing order of complexity. Your CPT assistant is going to be published for your reference material. It is a subscription service, but you will find references to it listed below the codes within the CPT book. The CPT assistant does offer articles that answer your everyday coding questions, NCCI bundling information, E&M billing guidance, current code use and interpretation, case studies demonstrating practical applications of some codes, anatomic illustration charts. You've got some information for appealing insurance denials, and then any information to validate code usage when you are audited. Again, it is a subscription service, but it is considered an official resource, so you can use that for support when coding your services. When we talk about the surgery section of CPT, you will have surgery guidelines. So we have what's known as a surgical package, and that's going to include the 6 bullet points that are listed here. It includes your local infiltration, any blocks or topical anesthesia. So if you do any injections of lidocaine, bupivacaine, basically any anesthetic that's injected, that's going to be included in your surgical package. Your decision for surgery, unless it is a emergent case, which we'll talk about that with modifiers and how to indicate an emergent case here in a little bit. But your decision for surgery for that global pack or for that surgery is going to be included in the global package. Any immediate post-op care, including dictating your op notes, talking with the family and physicians, that's going to be included. Evaluating the patient in the post-anesthesia recovery area, writing any orders that are necessary, and then your typical post-op follow-up care. So when you have to go back into the doctor's office for a 2-week check, or anything along those lines, those are all going to be included in your standard surgical package. When you have commercial payers, then those policies can vary. So again, it's just important to know who your payer is, and be familiar with their global package and what's included. But it's important to know that these can apply to procedures and services that are provided in any location. So it's not a matter of where the procedure that's being performed, it's a matter of what procedure is being performed, and what their global package is. So in order to identify the different types of global packages, then you have different major surgeries versus minor surgeries. You have a 90-day global package. It's going to be a total of 92 days. So you have a pre-op period of 1 day, so the day before the surgery. You have the day of the surgery, and then you have 90 days after the surgery. So again, it's 92 total days. It's just referring to that post-op package of 90 days, so 92 total days. If you have a 10-day global package, it's going to equal 11 days. So you have the day of surgery itself, and then 10 days post-op. And then you can have a 0-day global package, which is 1 total day, and it's just the day of, nothing before, nothing. Now, when we talk about our HCPCS codes, these are going to include any services that are provided to patients, which are included with the CPT. So HCPCS level 2 is going to include our ambulance, our drugs, any durable medical equipment, basically anything that's not included in the CPT. They're going to be maintained by CMS, and they will contain both permanent and temporary codes. Your permanent codes are updated on an annual basis, and again, they will go into effect on January 1st. Your temporary codes are going to be updated quarterly. HCPCS codes are going to be 5-character alphanumeric codes, and they will always begin with a letter. So J1234, E7649, something along those lines. Your A codes are going to include transportation services, including ambulances, medical and surgical supplies, any administrative and miscellaneous and investigational codes. Your G codes will include professional services that will specifically apply to Medicare patients, and additional quality reporting codes. You do have some codes that are going to be very similar with CPT and HCPCS code sets. So let's take a look at the G0412. through G0415, these indicate services that are unilateral or bilateral. So it could be either or. But if you look at the CPT codes for 27215 through 27218, then it's in a unilateral code only. So we would be able to use a modifier to indicate that the service was done bilaterally. And then you've got your H codes, which are going to be used by your state Medicaid agencies for your mental health services. So you're going to see your alcohol and your drug treatment services there. The ones that you'll probably use the most are going to be your J codes. These are going to be drugs that are given subcutaneously, intramuscularly, intrathecally, intravenously, orally, topically, or inhaled. The majority of your J codes will come with a specific dosage for your drug. So you want to be careful of the quantity that's reported. So for example, if you have a code that indicates 250 milligrams of a drug, but you inject 1,000 milligrams, then you would want to report 4 units of that code so that you could accurately describe 1,000 milligrams being injected. Now, you do have an appendix for the table of drugs and biologicals that will help you find the drug code, and you can look it up by either your generic or your brand name. As always with your index, you never want to code it directly from the table, but you always want to make sure that you validate that code within the tabular list. Your L code will, your L codes will include orthotic procedures and services, as well as any prosthetic procedures. Your key coding concepts are going to be your anatomic site, any number of services or procedures, the size, the type of the procedure, or even the product. Your Q codes will include your temporary codes. They can be added, changed, or deleted on a quarterly basis. Once they are established, then they are usually implemented within 90 days. And then the time that's needed to prepare and issue your implementation instructions, as well as enter those codes into CMS and the contractor's computer systems, as well as initiate any user education. And then lastly, you've got your S codes that will include your temporary national codes for non-Medicare use. Again, your key coding concepts will be the anatomic site, the number, the size, the type of procedure, the product, and then sometimes even the age of the patient is specified within your code set. Okay. So let's talk about those modifiers for a second that I've kind of been mentioning. So your modifiers are going to be the 2-digit code or 2-digit, basically a modifier that you can append to your CPT code in order to indicate that the service itself was somewhat altered, right? So modifier 24 is going to be for basically an office visit that's provided to a patient by the same physician during a post-op period for a service that's completely unrelated to the surgery. So an example for when you would append a modifier 24 is if you have a patient that has a surgery on their right knee. During that post-op period, the patient injures their wrist and then returns to the orthopedic surgeon. Since the patient is already within that global day period for the knee during which your office visit is needed, then the orthopedic surgeon would append a modifier 24 to that office visit in order to indicate that it was unrelated to the knee surgery. Your modifier 25 is going to indicate a significant or separately identifiable evaluation and management service by the same physician or other qualified healthcare professional on the same day of your procedure or service. So an example of that would be if they have to come in for just a regular office visit, but then they do earwax removal. Then you would put a 25 on the office visit, and then you would bill out the code for the earwax removal to indicate that they were done for the significantly different service. Modifier 57 is going to be used to indicate when a patient is seen and being taken to surgery within the next 24 hours. So when we talked about our global surgery package, remember we said that it includes the day before any major surgeries. So if it's done within 24 hours, typically that office visit or that evaluation and management service wouldn't be separately billable. However, if the patient is being seen emergently and they need surgery quickly, so if, for example, they go into the ER with right lower quadrant pain, and then the doctor decides that they have appendicitis and they want to go in and do that appendectomy before it ruptures, then they can append that modifier 57 to carve out that visit from the global package to say, without doing the exam, we didn't know what procedure needed to be done. Modifier 58 is used to indicate a staged or related procedure by the same physician within that post-op period. It can be a follow-up procedure that's more extensive than the original procedure, but it can also be used to indicate therapy performed following a surgical procedure. So, for example, a patient has a lesion that turns out to be malignant without clear margins. So the patient is then brought back to the operating room 7 days later, and they do a more in-depth surgery to remove the cancer, and that would be submitted with your modifier 58 to indicate that it is related to that primary or first procedure, but they didn't know that they needed to do it. Your modifier 78, that's going to be used when there's an unplanned return to the operating room for a related procedure during the post-op period. So, for example, you have a patient that has a gastric bypass surgery in January. In March, the patient is diagnosed with an incisional hernia at the location of that bypass incision. The patient will then be taken back to the operating room in March for that repair of the hernia. And since the hernia repair is related to the bypass surgery, we would use modifier 78 on that hernia repair code to indicate that it was unplanned but related. And then lastly, here you've got modifier 79, and that's going to be used to report an unrelated procedure or service by the same physician or other qualified healthcare professional during your post-op period. So, for example, you have a patient that has an open reduction of an ankle fracture that's done in October. In November, the patient has appendicitis and they have an emergency appendectomy. The appendectomy is going to be unrelated to the ankle fracture repair, so we should use a modifier 79 for that appendectomy, saying that it's unrelated to that open reduction that we had done previously. Modifier 22, that one is going to be appended to your CPT codes when the amount of work that is needed to perform the service was significantly greater than what's typically required. In order to support the use of your modifier 22, you do have to use the operative report and send that in along with the claim. And basically, that operative report has to describe the additional work, why the additional work was needed, any complications, any difficulty of a patient conditions, and things along those lines. Modifier 50, we've kind of already touched on that one. That's going to be appended to services that are done bilaterally. So you want to check with your payers to determine if they want the services reported with a modifier 50, or if they want to have the LT or RT for right and left on there. Some will prefer the 50, some will prefer the LT RT. Modifier 51 is going to be used when you have multiple procedures that are performed during the same session by the same provider. And those are going to be ordered in descending order, again, based on the RVU value. Modifier 52 is used to indicate your reduced services. So if a procedure is partially reduced, ended early, or eliminated at your provider's discretion, then you should append a modifier 52. And then your modifier 53 is going to represent a discontinued procedure. So this is going to be if a procedure is terminated due to extenuating circumstances, or if circumstances are present that threaten the well-being of the patient. So reduced services is it is terminated or ended early at the provider's discretion. 53 is it's discontinued and terminated due to the health of the patient. 59 is going to indicate a distinct procedural service. So you might use it for services that are not normally reported together. If there are services that are done on a different site or organ system within the same operative session, if there's a separate incision, excision, a separate injury, things along those lines. We've got some modifiers that talk about when you have two surgeons and they work together during the procedure. They're going to each dictate their own operative report, submit the same CPT code, and each append a modifier 62, indicating that that procedure did take two surgeons. And then your 66 is going to be for a surgical team. When you have multiple specialties, there's typically a minimum of 3 or 4. These are going to be for like your highly complex procedures, like your transplants, open heart surgeries, things along those lines. And then again, they'll all report their codes for the surgery, and then report a modifier 66. You've got some assistant surgeon modifiers that will indicate when you have help with a procedure, but they're not a co-surgeon. So depending on the different circumstances around the assistant surgeon, if they're there for a substantial portion, you would do an 80. If they're there for a short time and offer only minimal assistance, it would be an 81. If you're in a teaching hospital that employs residents, but that resident is not available, then you should use an 82. And then lastly, the last big section is going to be for global and your technical and professional components. So your professional component is going to identify the work of the physician to perform, read, interpret, or supervise the service. And then your technical component is going to identify the cost that's associated with the equipment, employing your technicians, your supplies, and things along those lines. So if you are a provider that is using equipment at a hospital, then your provider is going to be responsible for the professional component. And then the facility is going to bill for the technical component because they own the equipment. They own the building that it's housed in. They have to pay for the electricity, for the technicians, for everything that is related to the equipment itself. And then the provider, again, is going to bill for their professional component for that actual professional opinion, or supervising that procedure itself. So I know that was a lot when we got into CPT and the modifiers, but just in general, does the concept of CPT make sense to you? So ICD-10, yeah. So ICD-10 is going to be your conditions and your signs and symptoms. CPT and HCPCS are going to be your surgeries, your services, your procedures, and then any equipment or drugs or things along those lines to report. Okay. If you have any questions whatsoever, don't hesitate to reach out. I'm going to go ahead and stop the recording.